Hey everybody, it's Dr. Wood, and today we're going to be talking about Chapter 20, where we get into our endocrine disorders. So, there's a lot of reasons why patients may show up at the clinic with an endocrine disorder, and reasons for that could be due to a lot of signs and symptoms that are pretty common here. It can range anywhere from abnormal skin or hair changes all the way up to changes in mental status, fluid changes, a lot of different things here. Mainly because endocrine system is in control of most of the major body functions that you have. And so any changes there can cause some pretty significant effects. And so we know that the endocrine system is basically a network of glands that are secreting hormones, really. So anything getting secreted into the bloodstream to go and then, cause some sort of biologic change in a distant tissue is considered to be a hormone. And so these can include things like hormones coming from the pituitary gland, both anterior and posterior, include thyroid gland, adrenal. These are some of the ones we're going to talk about, being that they are most commonly affected by medications. And so our most common sort of therapeutic use for hormones includes replacement therapy, meaning if the patient cannot produce enough on their own, we can supplement that by giving them extra. Sometimes we try to go and give hormones in extra doses or higher than what you would normally release in order to provide some beneficial effects. So for instance, we can give corticosteroids in order to help deal with inflammation. We can give larger doses of, say, estrogen in order to stop ovulation and prevent pregnancy. There's a lot of different ways we can do that, but those are the two main major reasons why we give someone hormones. Now, getting into the pituitary gland, this is going to be one of the big master glands that sort of regulate endocrine function, and you're going to see that different substances will be released from both the anterior and posterior. Typically, the hypothalamus, which is located right above the pituitary gland, will be sending down some signals, but we'll mainly be focusing on what's coming out of the anterior and posterior pituitary. Growth hormone is a very common one that comes out of the anterior pituitary, and this stimulates growth of tissues and organs. Another name of it can be somatotropin, and if you are deficient in somatotropin, this can lead to things like dwarfism. Patients are relatively short. If you have too much production, that's where you can get gigantism and acromegaly. Think about like Andre the Giant. He ended up having too much growth hormone, which caused him to be quite tall. And so typically what we can do is supplement patients who are not producing enough growth hormone on their own. So if they have low somatotropin levels, we can supplement that. Now, you wouldn't just do this because, say, a child is short, but certainly if they were found to be deficient on their own. For instance, some kids may have a pituitary issue where they are not producing enough growth hormone, or maybe they had a tumor and they had to have pituitary resected. A lot of different reasons, but we go ahead and we'll administer somatotropin in order to replace that which they are missing. Another one that comes from the anterior pituitary includes the adrenocorticotropic hormone, or ACTH. This is used primarily to stimulate the adrenal glands, which we'll talk more in detail about later on. You'll see this is typically used as a diagnostic. If you want to see how well your adrenal glands are working, you can actually administer this via IV and stimulate the adrenal gland, and then you take levels of cortisol, which is the main hormone that your adrenal glands produce, and see how they respond. And so that can actually tell you quite a bit of things. So this one's not being used therapeutically, but more so diagnostically. Another very important one is going to be thyrotropin, or thyroid stimulating hormone, TSH. This is a common drug level or a substance level you're going to be getting on your patients here. And normally what TSH does will stimulate the thyroid gland to do things like increasing uptake of iodine, which it uses to produce thyroid hormones like T3 and T4, and it can actually promote thyroid gland growth. So you can actually develop goiters or an enlarged thyroid if you end up having too much TSH. And sometimes we use it diagnostically, but this is important to know just in terms of how it relates back to thyroid hormone. In the posterior pituitary, you're going to see things like oxytocin is really important. Now, oxytocin you may hear as being like the love hormone, and is really important in terms of like, say a mother is hugging her child for the first time. There's a lot of oxytocin that gets released there. People see, if you go and pet a dog, like levels of oxytocin rise in response to that. So it's a very positive sort of hormone. But it can also be used therapeutically as well. So if you have someone who's going into labor, we might actually give someone oxytocin via IV, and that actually helps to stimulate uterine contractions and can speed along the delivery. So that's one thing we can do. Another really important hormone here is also called antidiuretic hormone, otherwise known as vasopressin, or ADH. And basically this one's really important because it helps to regulate sodium levels in the body and also fluid levels in the body. So if I give someone antidiuretic hormone, it means anti-diuresis, meaning they're going to stop them from urinating. actually cause them to hold on to more water. That can cause sodium levels to drop, and that can cause some issues if there's too much of it. If you have too little of it, you can find that you don't have enough fluid, and then that can cause things like hypotension, and which can be problematic. And now looking at the thyroid gland itself, you notice here it's going to be located on the neck, and basically there's two large lobes, and there's sort of a central focus there right around the larynx. And so this is the largest gland that we have, and it can actually grow quite a lot larger depending on what kind of stimulation it has from TSH. The main hormones that it produces includes T3 and T4. To a minor extent, we'll talk about calcitonin in just a little bit, but T3 is the main active form of thyroid hormone. This is the one that actually causes most of your changes in the tissues. T4 is going to be sort of a stored sort of hormone where it gets eventually converted over into T3 where it becomes more active. Remember that it is stimulated by release of TSH. So that's what's going to cause levels of T3 and T4 to go up, right? And we'll see that T3 and T4 themselves will stimulate things like protein synthesis. It'll do things like increasing blood sugar levels, increase metabolism overall, raise blood pressure, heart rate, all those things there are related back to thyroid hormone, T3s and T4. Here's an example of what a goiter might look like. You can see it's a large sort of lobe as a result of too much stimulating hormones, too much TSH. So typically we're going to be looking at thyroid replacement therapy in terms of how we're going to be administering this as a drug. The most common one we administer is levothyroxine, otherwise known as Synthroid. This is actually T4, but we give it therapeutically, and then eventually it'll get converted over into T3 where it can have its effects on metabolism and whatnot. Normally when you're monitoring this in patients, you're going to be measuring levels of TSH and T4 to make sure you see how the drug is actually working, make sure it's working well. Keep in mind, we typically, while giving thyroid hormone can help promote weight loss because it increases metabolism, we don't do that just for that specific reason. We mainly are doing it to treat the hypothyroidism itself. So the patient's having low energy and they feel miserable, and their blood pressure's low and the blood sugar's low. It could be related back to having low thyroid hormone levels. This is something we can go ahead and treat, not specifically because they're overweight. So what we're going to do is start really low doses, and then we'll incrementally increase until we get sort of an adequate response, kind of where we want it to be. In terms of hyperthyroidism, this is usually due to hypersecretion of thyroid hormones, and that's going to be most often due to Graves' disease in a lot of cases here. And what you see is that when it's overactive, you see increased cell metabolism, you see weakness, anxiety, a lot of heat production. Typically, these patients are pretty sweaty because of all the excess heat they're producing. And so what we can do is either remove the thyroid gland entirely, either via surgery or with radiation, or you can actually end up using antithyroid medications. These medications are going to help to interfere with the synthesis of thyroid hormones, and that can include things like high levels of iodine. Now, iodine normally in low enough levels or sufficient levels stimulates hormone production. Here we see with really high levels that can actually help shut that down. If you use a radioactive iodine, you can actually have that being taken up into the thyroid gland where the radioactive particles can actually destroy the tissues. That's one way to get rid of it. It's more of a permanent way to do it. And then we also have the medications methimazole and propylthiouracil, otherwise known as PTU. Main side effects that you're going to see are nausea, vomiting, stomach pains, etc., sort of non-specific symptoms here. And keep in mind, we don't want to mess with thyroid hormone in a pregnant patient because it can arrest fetal development. Now, calcitonin is secreted by the thyroid gland, but it's working a lot with parathyroid hormone to make sure that we can regulate levels of calcium in the body. So, for instance, if you have high levels of calcium, calcitonin can go in and then help to decrease that potentially. And most often, we're going to see that we can actually give this as a nasal spray in order to help keep calcium levels in check. And what's interesting is that actually we use salmon calcitonin, which has enough, looks similar enough to our body that we treat it just like human calcitonin. So, it's kind of interesting some of the places we get our medications from. Now, getting into the corticosteroids, these are going to be things coming from the adrenal glands, and we have two of these sitting right above the kidneys, and basically these are going to be composed of the cortex, which are the outer portions here of the adrenal gland, and then the medulla, or the inner portion. We'll mainly be focusing on the cortex and on the hormones we're getting out of this. Now, as I mentioned, corticosteroids are going to be activated by ACTH, and that's coming from the pituitary. And these are really important for regulating a lot of things like carbohydrate metabolism. They have an anti-inflammatory, immunosuppressive effects that work to help regulate water levels. And so, very, very important. If you don't have enough of it, you can lead to some pretty big issues in terms of having low blood sugar, having low blood pressure. all those things there. And we'll talk about two delineations here for the corticosteroids, including both mineralocorticoids and then glucocorticoids, both of which get secreted by that adrenal cortex. The glucocorticoids, as you might expect, having gluco in the name, is going to help with regulation of metabolism of carbohydrates and some proteins. These also have a lot of anti-inflammatory effects. So if you were to have, say, like an asthma exacerbation, we can give you corticosteroids or glucocorticoids more specifically to help decrease that inflammation. You can also use it in patients who've had, say, a transplant, and it prevents the body from trying to reject that tissue because it's suppressing our own immune system. Typically, what you're going to find is that excessive high doses for long-term can lead to what we call Cushingoid symptoms or Cushing's disease, as I'll mention here in just a moment. And the most common glucocorticoids you run into include things like prednisone, dexamethasone, and methylprednisolone. Cushingoid symptoms include things like fatigue and weakness. You also find that they can have abnormal deposition of fat, so you can have this like kind of buffalo hump over the back of the neck, pot belly sort of features here, and then hirsutism or excessive hair growth. Not only that, but patients tend to get a little bit more moody when they're on these high-dose corticosteroids, and so this is why we like to try to prevent as high-dose use as much as we can and try to shorten up how long we're going to be having patients on corticosteroids. For the mineralocorticoids, you think mineral, you think salt, you want to think water, and so this will help to regulate levels of both sodium and potassium. The main one we have here is going to be aldosterone, and it's really important because it acts on the kidneys to try to regulate how we're holding on to sodium and water and can have big effects on the blood pressure. Now, when you're administering corticosteroids, it's important to know that there's a lot of routes here. Obviously, things like parenteral administration is going to be much faster, but sometimes we'll give it via routes like inhalation because they only work on the areas where they're being inhaled. So, for instance, for asthma, you have to limit a lot of the side effects by just having it affecting the lungs, which is nice. One thing to note, though, if you're on a systemic corticosteroid, being orally or parenterally, it's really important that if you're on it for longer than a week, you have to taper off the dose. The reason for that is because the corticosteroids, when they're around, they tell the adrenal gland, hey, I have enough steroid around, I don't have to produce any myself. And that's part of that negative feedback loop. It gets activated and will shut down adrenal function. So if you were to have someone who was on, say, a high-dose steroid for, say, 3 weeks, and they went off of it cold turkey, the adrenal gland takes time to kick back up into production, and so you undergo what they call adrenal insufficiency. And so this is why you have to make sure that if they're on it for longer than a week, you taper off the dose slowly. Could take a few weeks, could take a few days, depending on the situation. Now, getting into pancreatic hormones. So this is really important because of diabetes, right? We know that a lot of patients are diabetics. We know there's a lot of morbidity and mortality associated with diabetes, and this is why these medications are so important. Insulin, as we know, is going to be the primary pancreatic hormone that gets secreted that helps with glucose regulation. You're going to find that these are coming from the beta cells in the pancreas, and it helps to shuttle glucose into our cells where they can be utilized for energy. It also helps to store excess glucose as glycogen. It's kind of a storage molecule in the liver that gets produced when there's excess levels of blood glucose. Eventually, those carbohydrates get converted into fat, where they then can be utilized later for energy production. Overall, it should help to decrease blood glucose levels because all that glucose gets shuttled into the cells. Now, with diabetes, we know it's usually a disorder of carbohydrate metabolism to where they're either deficient in insulin, they don't produce enough of their own, or they have what they call insulin resistant, where the cells, they get exposed to so much insulin they say, hey, we don't really need any more around here, and so it becomes much more resistant. What that does is it leads to higher blood sugar levels. So there's kind of two ways in which this can happen, either insulin deficiency or resistance. And so the three classic signs you think about with diabetes is going to be polydipsia, where they're drinking a lot of water, polyphagia, where they're eating a lot, and polyuria, where they're going to the bathroom quite a bit and having a lot of urination. We have very large cause for death here in the United States, and a lot of other comorbid conditions that happen along with this, things like chronic kidney disease, things like neuropathies, etc. Now, there's type 1 and type 2 diabetes. This is sort of the most classic delineation here. Type 1 diabetic patients are typically diagnosed much younger in life, typically when they're children or adolescents. And basically, it's an autoimmune condition where their own immune system has attacked those beta cells and they cannot produce any more insulin on their own, which means that they have to receive exogenous insulin. We have to give it to them in order to make sure that they do not undergo hyperglycemic crisis and they potentially die from that. On the other hand, with type 2 diabetic patients, these are typically more of your later patients, say later decades of life where they have, usually due to bad nutrition, due to certain genetic predispositions, they become very resistant to insulin. We call it type 2 or non-insulin dependent diabetes. And that's not to say these patients will not go on insulin at some point, but it's not a starting point for them. They can still produce insulin for the most part, but you're going to find their cells don't really respond all that well to it. So what do we do in terms of treatment? Well, certainly we like to make sure we recommend non-pharmacologic treatment, including adjusting their diet, getting exercise, and then we'll look in terms of how we can manage this with medications, including insulin, oral hypoglycemics, or things that lower blood sugar, and things that can affect the actual absorption or production of glucose. So looking at the signs and symptoms, these are important to educate patients on, are things that can occur when they become hyper or hypoglycemic. So typically with hypoglycemia, it's much more of a sudden onset, and I like to talk about patients as being hangry when they're hypoglycemic, and most people have probably felt that at some point in their life. But typically you're going to find that they're going to be very irritable, they may be a little shaky, their heart rate's up, they're sweating potentially, and this is most often going to cause or happen when their serum glucose gets down below, say, 50 milligrams per deciliter. At any resting person, that's healthy, they may be sitting around between 70 to 100. This is relatively low for them. And so patients are oftentimes pretty aware of this, and they can correct this by taking glucose. On the other hand, hyperglycemia is going to be more difficult to determine, and oftentimes you won't notice this until they're very sort of late stage. And so you can find patients can become very acidotic, where their pH gets very low, their blood sugar is usually very high. I've seen cases where the blood sugar is 500-600 milligrams per deciliter, so quite high, and they may even have this fruity odor or an acetone sort of smell to the breath. That's one of the ways they would diagnose hyperglycemia. It's based off that fruity odor. So with administering insulin to type 1 diabetic patients here, most frequently it requires subcutaneous injection, mainly because insulin is a protein and the gastric juices are going to destroy that, so you can't take it orally. Previously, we only were used to getting this from pork or beef products, meaning the pork or the beef actual insulin was taken from those animals. Nowadays, though, we have recombinant ways to actually deform this, so it's actually made with recombinant DNA technology. Now, the difference in different insulin preparations, which I won't get into every one of them, are going to be based off their onset of action, how long they last, and their time to peak action. So we have some insulins that work very, very quickly. They're good around meal times to help deal with that large bolus of sugar that you'll get through your food. And then often we'll also give with them long-acting medications that kind of work 24 hours a day in order to keep the blood sugar in check. Regular insulin is basically the kind that you produce, or assuming you have insulin to produce, that's called regular insulin. That one's always clear. A lot of ones that are long-acting, they're typically cloudy because of some added precipitates to it. Normally, these can be put back into solution by kind of rolling the vials, or if you have an insulin pen between the hands. It's really important with any protein product, especially insulin, never shake or agitate it, because as it gets agitated, the proteins like to come out of solution and the product gets really foamy, and at that point the drug's not going to work all that well anymore. Okay. Also, it's important if you have syringes that are pre-filled or pens to make sure to store them vertically, so that way any of the precipitate doesn't get clogged into the needle. Now, there's a lot of different ways for patients to administer this. Traditionally, we do it with syringes and needles, but certainly there are pens where you can actually dial in a specific dose. There are pumps that patients can carry around with them, and they are almost like the size of a small pager, if you guys are old enough to remember pagers. But they're quite small. They can go right on their belt, and basically they have a subcutaneous catheter that goes right into the skin that constantly pumps out insulin for them. And even in some cases, they're inhalational routes, even though this is fairly rare and still pretty expensive. Now, I'm going to go through a couple of classes of the different hypoglycemic agents we have available to us, and we'll go over each one of these on our own. The sulfonylureas are actually kind of the first agents that we had here, and this is actually working by stimulating the pancreas to start to release its own insulin. So this would actually work very well for a type 2 diabetic patient who is still able to produce their own, but actually wouldn't do anything for a type 1 diabetic patient. Big problem with these is that as you release more insulin, hypoglycemia is a risk, and then also weight gains can be quite common with these agents here, which makes sense because as you shuttle more of that insulin into the cells, more of it can eventually be turned into fat. Okay, glipizide and glyburide are the most common agents you'll find in this category. We have some agents that will actually prevent absorption of glucose from the GI tract. So instead of having glucose being absorbed from the stomach, or from the intestine, I should say, they'll just go ahead and stay out there and then eventually be eliminated in the feces. The problem is, though, is we have a lot of bacteria in our GI tract, and they will work to break down those sugars, and guess what happens? Well, they produce a lot of gas, and so this is actually pretty poorly tolerated by patients because there's a lot of flatulence associated with them, abdominal distension, etc. And so patients usually don't like these drugs. However, two ones we have in this category include acarbose and the miglatol. The biguanides are probably the most common agents we would give to a type 2 diabetic patient, and actually it's probably one of the first line therapies you're going to give to them. And metformin or glucophage is going to be the most common agent in this category here. And what's nice though is that it does not cause any hypoglycemia because it doesn't stimulate the pancreas to release insulin. What it actually does is it helps to sensitize the cells back to that insulin again. So it helps to increase the sensitivity of cells to insulin, thus it's easier to move glucose into those cells. So basically kind of trying to reverse a little bit the effects of type 2 diabetes. Next we have the thiazolidinediones. Most people just call these the glitazones, and these are also going to be used as sort of a second line agent for diabetes, especially type 2 diabetes. Basically what they're going to be doing is help to improve function of the beta cells and actually help delay further progression of diabetes. Can see some weight gain with these, some edema, and the two main ones in this category include rosiglitazone and pioglitazone. Next we have the meglitinides. These actually work pretty similar to the sulfonylureas. The only difference is they only work around meal times when there's an increase in blood sugar levels here. And so we give repaglinide or neteglinide in these cases here. We'll give them along with meals in order to help secrete extra insulin to help deal with that increase in glucose. Next are the DPP-4 inhibitors. These are oftentimes used as add-on agents here, and basically they're also working as insulin sensitizers. They're nice because you see less hypoglycemia and less weight gain, and typically agents fit into this category include like sitagliptin or Januvia, which is the brand name for that. Next we have the incretin mimetics. So this is actually mimicking another hormone that our body produces that helps to do things like increasing satiety or that feeling of fullness after you eat a meal where you feel like, hey, I'm pretty good, I don't have to eat any more food. And so these drugs are pretty revolutionary because they're actually really good to help sensitize the body to insulin. They have to drop weight usually because they help to increase that satiety. However, they do have to be given subcutaneously because they are proteins. And so this is something patients may or may not be totally down with, especially if they're pretty needle phobic. But a common one in this category includes exenatide, otherwise known as Byetta. What do we do if the patients are hypoglycemic? Well, we can raise the blood sugar up, and there's two main ways we can do that. Either by giving just plain dextrose, which we can do via IV. Sometimes we'll give them sugar tablets where they can just go ahead and take a few of those and help to raise their blood sugar. Or we may give them an injection of a product called glucagon. Now, glucagon is also a hormone that your pancreas produces, and it works to help raise blood sugar because it stimulates the liver to produce its own new glucose. It's a process called gluconeogenesis that it undergoes. So a couple ways we can try to get the sugars back up for patients who are hypoglycemic. That's the end of this section. If you have any questions, let me know. I'll talk to you soon. Thanks a lot. Bye.